15 दिन हो गए पूरे पूरे यूट्यूब चालू नहीं करा है ना 26 नंबर का। पूरे पूरे 15 दिन हो गए। पिछले दिन की बात है मामला की, आज तो 15 दिन हो गए बोल दिया सर। आप चेक किया था सर क्या टिप चल रहा है कि नहीं चल रहा? अच्छा किया था। अब तो यूट्यूब पे अपलोड कर सकते हो, क्या फायदा सब यूट्यूब पे नहीं चल रहा है जब। मैं अभी जाकर सर चेक करता हूँ सर। रेडी, बहुत शुक्रिया। मैं भी जाकर ऊपर चेक करता हूँ तो यार। वो भी चालू करवाना है उससे आईपैड का वो प्रैक्टिस करनी पड़ेगी खराब हो तो जो चालू है वीडियो कॉल कर रहे
Asim?
Good evening, sir.
Asim, can you hear me?
Yeah, I can hear you, sir. Hello.
Asim, can you hear me?
Yeah, we can hear you, sir. We can hear you.
Yeah. Good evening.
Good evening.
I'll just share my screen. How do I do that? Can you see my screen, Azim?
Yes, it is seen.
Yep. What time do we start? We'll wait for another 5
We
minutes.
just wait for another 5-6 minutes and then we'll start.
Sure. Yeah.
Deepak Balasubramanian. स्टार्ट हो गया टिकट
Morning, everyone. Sorry, good evening, everyone, and welcome to Mahamana Case Discussion Series. And today's topic is on salivary gland tumors, and we have Dr. Deepak Balasubramanian with us. He's a professor of head neck surgery at Amrita Institute of Medical Sciences, Kochi, and he'll be speaking on facial reanimation in parotid surgery. Welcome, sir.
Thanks, Azim. Shall we start?
Yes, sir. Yeah, please.
Yep. Okay, so good evening, everyone, and thanks, Azim, and everyone for this opportunity. So I'm going to speak on a topic that I feel personally that every head neck practitioner should know. It's not complicated. It's not very difficult to do. The problem is there have been very few avenues to learn facial reanimation, especially when you do radical parotid surgeries or you see patients coming back after previous parotid surgery to you with facial palsy. And all these cases have been relegated to few practitioners of plastic surgery, and we've been largely left out from managing these patients. But it's a very easy concept to do. It's a very easy surgeries to do. And hopefully through the next 30 minutes, I would try to share some of my experience with all of you. So before we go to facial reanimation and facial re-innervation, we need to understand the anatomy with the thought that how do you identify the facial nerve stumps once there is radical removal of the nerve, or when you go back in for a secondary procedure later on. So we need to know where to find the nerve stumps, either the facial nerve or substitutions of the facial nerve. So we need to have some idea about the anatomy. The significance in parotidectomy is both oncological, and sometimes even if the nerve is in continuity, the patient does develop long-term paralysis. What are the variations of the facial nerve? Now, this is important because we have to understand that these variations can affect the end organs or the end effectors of function. What are the anatomical approaches to the facial nerve? What are the disease approaches? How do you manage a cut or sacrifice nerve? And what are the long-standing palsy managements? Now, one of the basic things that most of you must be ENT surgeons, one of the basic things that we have to understand is that there is an intratemporal and extratemporal course of the facial nerve. The reason why we need to understand the mastoid anatomy of the facial nerve is that we, in certain cases, would have to drill the digastric ridge. That is where the digastric muscle is attached to get a proximal stump of the facial nerve. So you can see in this picture, the lateral semicircular canal is one of the landmarks. The other landmark is the short process of incus, and this is a facial recess. And in some cases, you can use the chorda tympani to identify the mastoid segment. In many cases, especially like adenoid cystic carcinoma, when you send frozens and you find the proximal segment has some disease, or it could be any other sort, salivary ductal carcinoma, you need to open up the mastoid to get the proximal driving nerve, unless you want to do some nerve substitution. So in certain cases, per primum, we would have to drill the digastric ridge and expose the intratemporal course of the facial nerve. So this is the anatomy of the reachable temporal course of the facial nerve. So once the facial nerve comes out and becomes extratemporal, you've got to understand the planes that the facial nerve follows. So as we go from superficial to deep, from superior to inferior, the superior branches are more superficial. That is the temporal branch and the zygomatic branch. And as we come closer down to the angle of the mandible, the branches are slightly deeper. So you have to understand the levels of the facial nerve. Now, why is this important? This is important if you're doing retrograde facial nerve identification, or you have sacrificed a segment of the facial nerve and you want to seek the distal stump of the facial nerve for anastomosis. So you've got to understand that there are different planes of the facial nerve. Now, the two common branches that can be sacrificed during radical parotid surgery are the buccal branches. They run on the masseter, and they are related to the transverse facial artery. And as we come further down, you see the marginal mandibular nerve crossing the vein, the retromandibular vein, and below that is the cervical branch. Now, I have to tell you that don't take the cervical branch lightly. This and the platysma interdigitates and is inserted into the lower lip. So even if you preserve the marginal mandibular, you can still have lip eversion problems or angle of mouth deviations that could result in palsy. And the other important thing that you've got to remember is that the marginal mandibular nerve is described as a neural hammock. It's not a single nerve. Sometimes there can be 2 to 3 branches, but this is usually after its course over the angle of mandible or the retromandibular vein. Now, what are the anatomical landmarks for identifying distal branches? So this is for the frontal, zygomatic, buccal, and the marginal mandibular branches. Now, this is important if you cannot find the nerve during intra-op dissection and you want to use a superficial anatomical landmark, and these are important to remember. Now, the description of facial reanimation is that facial reanimation is used to create apparent lifelike movement of the facial muscles. Remember the word apparent and lifelike movement. Sometimes you will be able to re-innervate the distal branches and the individual end muscle plates or the effector muscles, but sometimes we have to mimic that movement through different reanimation procedures. And there are various dynamic and static procedures that are available. So what are the problems with facial palsy? And these are the signs that you've got to look in the patient. Obviously, one of the most common signs is that the patient has inability to close the eye. But the functional aspect of that is eye irritation and epiphora. And patient can also have visual field defects if the frontalis doesn't work because there is ptosis of the brow. So don't take the frontal branch lightly because this will cause ptosis, this will cause closure of the palpebral fissure, this will cause closure of the iris, and the patients will have visual field defects. Now, this is important when you're trying to rehabilitate the eye. Already with a patient with ptosis, if you load the eyelid with a gold weight or you try temporalis, it's going to make his symptoms worse. So during surgery, please be careful. It is the most superficial branch of the facial nerve. And even if you do facial nerve monitoring, in many instances, if you don't use the 4-probe technique, you will never be able to sense if the frontal branch is being affected. And the other things that are speech difficulties because of lip incontinence, drooling. And the other important thing is nasal obstruction. Many patients who have buccal branch problems, the ala collapses. So when the ala collapses, they have nasal block and they also have symptomatic problems, aesthetic problems. So you also have to think of reanimating the buccal branches. But like I said, it is one of the commonest branches sacrificed during radical parotid surgery. But you have to remember that this also has long-standing problems. Now, this is what was taught to us during our residency in ENT. There are several facial electrodiagnostic tests that are used. In all honesty, in a head and neck practice, for parotid malignancies, none of these are used except for the fact if you have the nerve in continuity. If you have the nerve in continuity, you can see for early recovery of the end plates or the nerve, or you can check the muscle potentials after 12 to 18 months to see for recovery. But in my clinical practice, sorry. Can I continue?
Yeah, please.
Yeah,
I think
so
whoever is joining, please mute yourself on joining and please check it. And it's impolite to speak when somebody is speaking and giving a lecture.
So my only concern when I think about these electrodiagnostic tests is two things. One, I would like to know if the nerve has been preserved during surgery, and then I would wait 12 to 18 months to see for the nerve recovery. But if the nerve has been damaged during surgery, then you think of repairs or substitutions. If you know the nerve has been damaged for surgery and no attempt has been made to repair the nerve, then you have to think of the various dynamic and static procedures. All of these techniques have been described for probably traumatic facial nerve palsies, mastoid injuries, but from a radical parotid surgery for malignancies, in my clinical practice, I don't use any of them. And these are some of the other tests that we can use. Now, there has been specific timings for each of these tests. So EMG is what we usually use. And if there is spontaneous recovery, let's say you preserve the nerve, the patient is worried. If you have spontaneous recovery in 3 weeks, it is pathological spontaneous recovery. That heralds a high probability of an incomplete recovery. But if the volitional actions are intact, then there is no problem for the patient. Now, there are several variations in facial nerve. There's a type 1 to type 6. These just look at the patterns of branching of the facial nerve. Why this is important is that when you're using nerve stimulation during your parotid surgery, you have to understand that the more distal you go, you can check for the individual muscles, but they will not account for proximal injury. So I've seen a lot of young surgeons and trainees stimulate the nerve close to the effector muscle, but they don't check proximally and they don't understand that there are variations in the anatomy. And they say that at the end of the procedure, the nerve was stimulated. But the nerve stimulation should be at the proximal most trunk. And please understand that when you're trying to re-innervate by using a cable graft, these are the various possibilities of facial branching that are seen in patients. And this is again a picture to show you what is the different levels of the facial nerve at different areas. So you can see at the frontal area, it's below the frontalis muscle. In the mesenteric area, it's just below the SMAS. As you come to the preauricular area, it's in the periparotid fascia. As you come down, it's under the platysma. And as you go closer to the angle of mouth, it's over the masseter muscle. So this is helpful for retrograde dissection of nerve to identify the nerve, and also for you to identify the nerve for a cross-face nerve graft if you're planning for a free functional muscle transfer. So these are some of the landmarks that people have used. This is a nice paper by Canotra in 2020. So there's posterior belly of digastric tympanomastoid suture, tragus, retromandibular vein, retrograde dissection. I always just use the tragal pointer because it's reliable. Even in patients who had revision surgery, it's reliable. I don't like to dissect too much at the posterior belly of digastric and spoil the cervical branches. So my practice of choice is just use the tragal pointer and be done with it. Now, at identifying from the periphery, again, you can use the marginal mandibular or the buccal branch. The marginal mandibular less so, the buccal branch better, because the buccal branch is on either side of the parotid duct, and the buccal branches have distal interconnections. So even if you damage one, the interconnections from the other will not affect the effector organs. Now, there are different types of facial nerve problems. So there's facial palsy. That's a movement disorder, which is temporary and or permanent, and can include facial paralysis, flaccid facial palsy, and non-flaccid facial palsy. Facial paralysis is complete absence of movement. The flaccid facial paralysis, that there is no tone, that indicates a long-standing facial palsy, either per primum when you see the patient with a parotid malignancy, or if you see the patient who has an intact nerve on follow-up, or a patient who's had the nerve cut and no attempt made at repair. Non-flaccid palsy is quite good because there is still some innate muscle potential available, and this helps in our reanimation. And facial synkinesis is a bad state where there is cross innervation because of aberrant healing, and this is a very difficult problem to correct. So what is the timing for facial reanimation or planning for facial reanimation? Timing is the most important thing. Then the availability of donor nerves, availability of recipient nerves, flaccid versus non-flaccid paralysis, and non-surgical adjuncts. So the basic principle is if the nerve goes through the tumor, you resect it. The chances of resection is more if there's pre-op palsy, obviously, and in recurrent tumors. Deep lobe extensions, a total parotectomy may lead to transient paresis, which will recover in most patients, but a small subset might have persistent palsy. So there are different systems for scoring facial palsy, and these are some of the systems. What we commonly follow is the House-Brackman and Sunny-Brook systems. Now, in the flaccid facial palsy, what are the things that you want to correct? So you want to correct the brotosis, and then you want to correct all the epiphora problems and the wide palpable fissure in these patients. That can be done by a lot of techniques. The nasal valve correction has to be done. That can be done by suspensions. Then there might be de-innervation to the lip that can be done with fillers to improve the lip bulk, or you can do free functioning muscle transfers or static transfers. In a non-flaccid facial palsy, it's mostly the same thing, but you have to remember that the tone of the muscle is quite good. So it's just mostly nerve transfers without, or free functioning muscle transfer without de-innervations or injecting fillers. So what to do if the nerve has to be sacrificed? So first you do nerve repair primarily without tension. That can be done by an 8 or a 9 nylon suture. The second is nerve grafting. There are different donor sites for nerve grafting. And then the third is nerve substitution. When there is no proximal nerve to drive the distal nerves, you think of nerve substitution from other cranial nerves. So one of the common things people do is try to re-anastomose the nerve. So there are different types of repair. There is epineural repair, there is perineural repair, and there is something called group fascicular repairs. It's impossible to do group fascicular repairs unless you do a big nerve like the radial nerve. So what I normally do is the epineural repairs. So you've got to bring the ends of the nerve close to each other, take stitches to the epineurium, prevent any sprouting of the fascicles. Now you got to remember, when you do this nerve to nerve anastomosis, it doesn't mean that the axon is going to automatically connect to each other. The axons will die. So this only becomes a conduit for the nerves to regenerate from the closest node of Rouvier. So you have to make sure that it is closed completely, and just few stitches and tissue glue would help solve the problem. Now, how long does it take to recover? It can take anywhere from 9 to 12 months for the facial nerve function to recover. And I would recommend this only for the distal nerves. If you do this with a proximal stump of the facial nerve to a distal stump of the facial nerve, there'll be gross synkinesis. So even this anastomosis has to be selected. Remember, think of the eye and the angle of mouth separately. If you do this with the proximal stump or in the mastoid, you will have a lot of synkinesis, and you might have to do chemical de-innervation later on to control the synkinesis. But the basic principle of repair is epineurium to epineurium, 0-180 degree. I would put a drop of tissue glue and cover it up with fascia or Surgicel so that the area heals well. And there should be no blood in the field. Remember one thing, if there is blood in the field of a nerve repair, the blood cellular agents will phagocytize the suture, the anastomotic site. So it should be bloodless. So all the scavenger cells in the blood in the field, don't leave any blood in the field also. Earlier, the concept was add a drop of blood on top of the anastomosis, the fibrin will separate out and act as a seal. But it has been found that if there's blood in the anastomotic area, there will be very poor anastomotic healing. Now, what are the nerve grafts? Let's say that you're not able to coap the nerve primarily. So you have a lot of nerve grafts. Remember, the nerve grafts are sensory nerves. You cannot take a motor nerve for a nerve graft because you'll be sacrificing the function at the donor site. So there are several nerve grafts that you can use. Greater auricular at the surgical site. You can also use cervical plexus. You can use supraclavicular nerves. You can use the sural nerve. Sural nerve is what we commonly use. But the problem with the sural nerve is you cannot do it in patients who have diabetic foot disease or have peripheral neuropathy, because you take away the sensations from the sole of the foot and the patients will have problems. So the easiest thing is the greater auricular, but it doesn't have that much length. Sural nerve has got a lot of fascicles, so it's preferred. You can harvest a sural nerve graft without making a long incision with a nerve stripper. You can use the sural nerve in multiple splits. So it's a better nerve, but try to avoid it in patients who have peripheral neuropathy. Now, one of the things that has been suggested is that can you get a nerve with the branching patterns of the facial nerve, even though it's not recommended? So the medial antebrachial cutaneous nerve of the arm has a branching pattern which you can use, but it's very small caliber and does not have that many fascicles or that girth for you to suture it to the facial nerve, to the end nerves. Now, if you don't have the facial nerve, let's say your multiple frozens from the facial nerve are positive for disease, or the facial nerve is diseased, and macroscopically and microscopically you cannot ensure a clear margin. Taking a diseased nerve and anastomosing it to the distal nerves is not going to work because the nerve is diseased. So you've got to think of nerve substitutions. That is, other cranial nerves that you can use to connect to the distal branches of the facial nerve, and your brain, your cerebral cortex will relearn. So that the action of that cranial nerve will incite an action of that facial nerve. So there are a couple of substitutions that you can do. I always prefer the nerve to masseter because it's a very strong nerve. It's very easy to dissect if you follow it from the sigmoid notch and come towards it's in the same field because you're raising a cheek flap. There are two branches of the nerve to masseter. You can use either one. And when the patient clenches after training and retraining and exercises, the angle of mouth might move. I usually use it for the angle of mouth alone because it becomes very debilitating that whenever the patient chews, the eye closes if you give it to the eye branch. So I prefer it if it's done to the angle of the marginal branch rather than the eye branch. The problem with hypoglossal nerve is that you always have a risk of tongue atrophy and tongue palsy. So I wouldn't usually do to the hypoglossal nerve. There are techniques called hypoglossal jumps, where you cut a circumference of the hypoglossal nerve and then take a nerve graft and connect it to the distal branches of the facial nerve. But the problem is the hypoglossal nerve is not a linear nerve. It's a twisted nerve. It's braided and twisted. So even if you cut a circumference of that nerve, you might end up with total palsy of that hypoglossal nerve. Now, when do I do a mesenteric transfer? In most cases, I do it immediately for the angle of mouth, and I would do a stage procedure for the eye. Either I would do a gold weight temporarily, or I would do a temporalis transfer later. If you're doing a free functioning muscle transfer up front, I would do it as an interim procedure till the opposite side cross face works, or I would do it as a permanent procedure. Now, these are the things that I was talking about. This is a full hypoglossal transfer in the first instance without a nerve graft. Then there's a split hypoglossal, which is called the jump, where you make a small scalloped incision on the hypoglossal and connect it with a nerve graft to the facial nerve. But all these are bad because there will be a lot of synkinesis in the patient. And this is a split hypoglossal transfer. And this is the nerve to masseter transfer. Of all of this, the safest is the nerve to masseter substitution. So this is a patient who had a hypoglossal transfer. This was a split hypoglossal transfer. And this is a patient who had a mesenteric nerve transfer. And this was only done to the angle of mouth and not to the eye branch. So how do you identify the nerve to mesentery? It's quite easy. You draw two lines. One line is about 1.5 centimeters along the zygoma, and there's one line which is 1.5 centimeters below the tragus, and there's a diagonal line drawn in between. And if you just dissect through the nerve to mesentery, you will find two branches, the anterior and posterior branch, sometimes three, and you just select one branch to connect to the facial nerve. Remember that when the patient chews, the angle of mouth will move, but in 3 or 4 months, this mechanism will become automated. So this is a patient who had, I'm sorry, the video is not working. So this is a patient who had a nerve to mesentery to facial nerve transfer. And this is her when she's clenching her teeth. You can see the angle of mouth is moving. Now, there's another way of minimizing this de-innervation. You can see that it was a long-standing palsy. This part of a lip is de-innervated and atrophic. So in those patients, you do a wedge resection and primary closure. That brings more bulk of the lip back to the commissure, and that helps in a lot of patients. Now, there's something called, if you don't have ipsilateral nerves to drive your facial nerve, you can use contralateral facial nerve. So the contralateral facial nerves, there are various techniques. There is the Scaramellas technique, Fisher's technique, Conley's technique. It's all it's all basically the same thing. But how do you decide which contralateral facial nerve branch that you will take? So what you do is you do something called the lignocaine test. So what you do is you select the contralateral branch that you want to do, and then you place a pledget of 2% lignocaine on that contralateral buccal branch. Usually it's from the buccal branch. And then you stimulate the facial nerve at its origin to see if all the buccal branch functions are still intact, meaning that the upper buccal or the lower buccal has interconnections between the buccal branches, and you can sacrifice that buccal branch. It's called the lignocaine test. And there are various ways of taking that buccal branch to the opposite side. You can take it under the lower lip. You can take it above the upper lip. You can take it through the neck. There are various ways of doing it. But please make sure you do the lignocaine test before you decide which branch to take. So what are the management principles? So rehabilitation can be immediate or delayed. Okay. So the things that I told you were the immediate sort of things that you can do, but there are other immediate techniques that we have. One is the gold weight implant, and what we usually use is 1.6 grams, and that is 24 karat gold. I'll show you a brief video on how it's placed. It's placed on the tarsal plate in the midline, just under the orbicularis. And then you have to test it in the OPD by putting the gold weight and putting a tape over the eye to see which one passively closes the eyelid. If it's too heavy, the patient cannot open the eyes. So you test it with different gold weights. It's malleable, it's bent, and it's got a hole for securing it during your surgery. So that is the immediate thing that I would do for an eye when I'm thinking of other things for the angle of mouth, like nerve to mesentery. So you have to think of correction of the deformity of the oral commissure and to correct lag of thalamus. So the oral commissure, if you want to do immediately, you can think of doing a facial sling, but that is static. So patient's face will always look as if the patient is smiling. But there are dynamic things that we can do apart from the nerve transfer. So these are in situations where there is no nerve for you to do anything. So one of the nerve transfers that was done before was the temporalis transfer for the angle of mouth. So you detach the temporalis from the coronoid process and suture it to the modiolus. So it's the deep temporal nerve that supplies the temporalis muscle and the deep temporal artery. So you can just make a parotid incision, extend it cranially, detach the muscle from the coronoid process and suture it to the commissure. And the other one was the mesenteric transfer. I'll show you that in some pictures. So in mesenteric transfer, what they do is they leave the origin of the masseter at the zygoma and taking care not to damage the mesenteric nerve. You detach the mesenteric muscle from the angle of mandible and from the lower ramus of the mandible. You split it into two, making sure you don't damage the nerve, and you can insert it both into the upper and lower lip. This is a very easy procedure to do. So this is a patient who had a mesenteric transfer. This was not for a parotid malignancy. This was for a hemifacial microsomia. And you can see that after the mesenteric transfer, the patient has good excursion of the angle of mouth. Now, the temporalis transfer is a very funny thing. Previously, we used to use the temporalis muscle for both the angle of mouth and for the eye. And we stopped doing that because we found that, again, it causes synkinesis or it doesn't work very well. So we have stopped doing this. What previously was described was something called the Labes procedure, where you detach the temporalis and you suture it to the angle of mouth at its tendon. But it's you don't want to sacrifice the temporalis because that is the only dynamic way of rehabilitating the eye. So there's something called functional muscle transfers. What we do is we take a gracilis muscle from the leg along with its blood supply and nerve supply, and then we suture it between the temporoparietal fascia and the angle of mouth. Again, this is only for angle of mouth. It's a free functioning muscle transfer. You have to do anastomosis. The anastomosis can be done to the facial artery and facial vein. The nerves can be either the facial nerve, nerve to masseter, or a cross-face nerve graft. So this is a patient who had a cross-face nerve graft. So a free graft of the nerve was placed from the contralateral normal facial nerve, taken across the upper lip and taken to the contralateral side. Now you can do this as a single step or a two-step procedure. The problem with this cross-face nerve graft is it takes time for the nerve to come to this point. And by the time the gracilis muscle, which is a free functioning muscle transfer, would have atrophied. So there are two ways of overcoming this. Either you do a two-stage procedure where you put the nerve here, you take the nerve from the normal side with the nerve graft and take it to the opposite side and do something called a Tinel's test. So when you tap on the nerve, the patient should feel some tingling. So that is one way of knowing that the nerve has grown to the opposite side. And then you do your gracilis transfer and the muscle will work. The position. So you put the gracilis here, you do dual innervation and take the nerve to masseter will heal earlier and will be able to maintain the tone of the muscle, and that the cross will work. Now, the good thing about the cross face is that it allows for mimetic movement. So when you smile, the opposite side will also excurse in a symmetric movement. So here you see the gracilis muscle, suture to temporoparietal fascia and to the angle of mouth. So the most important thing for the eye, apart from the gold weight, which is temporary, because gold weight can extrude, it's not a long-term solution. The best solution is the temporalis transfer. So this was one of the earlier ways we used to do temporalis transfer. So we used to raise the temporalis muscle, just the central part of the temporalis muscle. The temporalis muscle has the true fascia. So we used to raise the true fascia off the muscle and make it like this. Then we used to tunnel it under the upper and lower eyelids with these two ends of the temporalis fascia and suture it to the modulus. It's an extremely simple procedure. But the problem we realized was it left a big hollow in the temporal fossa. So we have slightly modified it. I'll show you a video of that. And this is one of the scoring systems called eFace, which you can use to score. I'm not going to go too much into this. It's a computer software that you can use to score your patient's outcomes after surgery. And these are some of the papers that have looked at how people have tried to use different underlying techniques and different techniques for reanimating the face. But the common principle is that you look at the eye and the angle of mouth separately, and then the nasolabial groove and the alar compression you treat it with a static graft. So if it's a permanent nerve palsy, nerve substitution, and manage the eye and do a gracilis transfer. If it's temporary, check the Bell's phenomenon. If the eye closure is adequate, nothing has to be done. But if the eye closure is bad, then do a gold weight. This is temporary. But permanent procedures are, excuse me, permanent procedures are for the eye is using a temporalis muscle transfer, or you can do nerve substitutions with the masseter. And if you have long-term facial palsy, you look at the eye and the lower face separately. For the eye, it's always a temporalis transfer. For the lower face, it's either masseter or temporalis transfer. If you don't want to do free muscle transfers, or you do a free muscle transfer with both the masseter and cross-face nerve graft. So look at the timing, look at your options, separate the facial sites, flaccid versus non-flaccid palsy, and decide whether you want to do a immediate or delayed nerve reconstruction. So I'll just show you a video, a quick video on the temporalis transfer, because it's something that every one of you should be able to do. It's not a very difficult procedure. Azim, can you see my screen?
Yes, it is seen.
Yeah, so what you do is this patient had a temporalis transfer and gracilis transfer. So for temporalis transfer, you make a zigzag incision on the temporal area, and this was for the free functioning muscle transfer. So once you do it, the next step is to identify the temporalis muscle. So make the incision, and then you identify the temporalis muscle under the fascia. Then you divide only the superficial fibers of the temporalis muscle from its attachment towards to the coronoid process. Only the superficial muscle, not the total deep. This is completely different from the previous video where I showed that you cut the temporalis in a rectangle, flip it, take the temporal fascia and go to the eye. This is our newer modification because it doesn't have a hollow, and it's along the vector of the temporalis contraction, and it doesn't form a bulge here in the lateral canthus whenever the patient tries to use the temporalis. So you make this, you just raise the superficial fibers of the temporalis. Don't go all the way to the zygoma, just the superficial fibers of the temporalis. Once you do that, if you follow the old technique that we have been using, we had the temporal fascia to form the sling. But in this case, we have to harvest a palmaris longus tendon to act as the temporal sling. So this can be done by multiple stepladder incision. The palmaris longus is a vestigial tendon, so you don't have to worry about it. If you can't find the palmaris, some patients don't have the palmaris tendon, you can always use fascia lata. But palmaris has paratenon on it, so it slides very well. It doesn't get fibrous to the skin or the underlying structures. So you raise the palmaris tendon, then you loop the tendon like this, okay? So the whole point is this part of the tendon should go to the medial canthus. One part of it comes to the temporalis muscle and the other part of it comes to the other side of the temporalis muscle. But how do you tunnel it there? So you have to attach silk sutures and make 3 incisions, one on the upper and lower eyelid, just above the just below the orbicularis. And you have to make 1 incision here to identify the medial canthal tendon. So this is how it goes. So you make the incision in the medial canthus, identify the medial canthal tendon, because the palmaris longus tendon has to go under the medial canthal tendon, and you have to take a suture. So you use silk sutures to pull it back to the temporal area. So the upper lid and lower lid, you're pulling it. Here we have not made the incision on the lid, but we made an incision on the lateral canthus. Bring the two slings and suture it onto the temporalis muscle, the cut end of the temporalis muscle. That's it. It's a very simple procedure. It takes less than half an hour to do. And this is how the patient looks after he clenches his teeth for the eye closure on that side. So it's an extremely simple procedure. It's not very difficult at all. I strongly suggest, I'll post this on my YouTube channel in some time, but it's very simple to do. So I suggest that all of you try doing it. The next is the gold weight implant. Can you see my screen?
Yes, sir. Yeah, it is seen.
So these are the temporary implants. These are not gold. These are the same weight as gold, which we use to tape onto the patient to see if the eye closure is adequate and that they don't have ptosis because of the weight of the gold weight. But introp, you make an incision on the upper eyelid, just above the lash line. Make an incision, dissect out the orbicularis oculi, and identify the tarsal plate. Now, this should be in the midline. Some books like Mark May says that you have to put the gold weight slightly more medial, but we usually put it exactly in the midline for the patient. Now you can secure the gold weight there are two holes on the gold weight. So you can put vicryl rapide and then secure it there. And this whole procedure is done under local anesthesia. So the patient can show immediately that they're closing. Now you've got to be very important. You have to approximate the gold weight, the orbicularis on the gold weight. You have to close it properly. Otherwise, the patients will have extrusion of the gold weight. So these are some of the procedures that we normally do. It's not very complicated, like I keep saying again and again. And have your principles set in stone so that you don't have any confusion about what techniques to use, or when do you do early, when do you do late. They should be in the armamentarium of all head neck surgeons. Whether you do oral cavity, whether you do neck or whatever, the gracilis might take some time for you to understand, but there are several local transfers, several local techniques that you can use to rehabilitate a patient with facial palsy. So thank you for your time. If you have any questions, I'll be happy to answer.
Thanks a lot, sir. There is one question in the chat box about how do we avoid synkinesis if we use temporalis muscle for eye and the angle of the mouth?
How do you avoid synkinesis if you use
temporalis muscle for eye and the angle of the mouth?
You can't avoid synkinesis. See, the only way you can avoid synkinesis is by injecting Botox. That is for neural repairs. That is if you want to do neural repairs, or if you've done one stump to all the other stumps, you can do that. But it's very difficult in a temporalis transfer. That is why I don't do temporalis for both angle of mouth and the eye. I do temporalis only for the eye and something else for the angle of the mouth.
Thank you, sir.
Physiologically, it's a very bad thing to do if you're doing temporalis for both. It's not recommended at all. Absolutely not. Any other questions?
So we'll have any other questions are there, then we'll discuss it during the case presentation.
Moving on to the case presentation. Today's topic is salivary gland tumors, and it will be presented by third-year MCH resident from Kidwai Memorial Institute of Oncology, Bangalore, Dr. Chandra Mohan. And I would like to welcome all the examiners. Dr. Deepa Nair, Professor, Head and Neck Surgery from TMH Mumbai. Welcome, ma'am. Dr. Bikramjeet Singh, Professor, Government Medical College, Amritsar. Welcome, sir. And Dr. Satakshi Chatterjee. She's a consultant head and neck surgeon from Apollo Hospital, Navi Mumbai. Welcome, ma'am. So let's start with the case presentation.
Good evening,
Chandramohan.
everyone.
Good evening, everyone.
Good evening.
You're able to see my PPT?
Yes. Can you make it full screen?
Yeah, yes. Good evening, everyone. Today I'll be presenting a case on parotid. So started. This is 32. He had a 32-year female housewife from Tumkur district of Bangalore. She came with a complaint of swelling in the left side of the neck for the past 8 months. Swelling behind the angle of the jaw and below the ear lobule for the past 8 months.
Chandramohan, 1 minute. Deepak sir, we would want you to stay as an examiner too.
Yeah, okay.
Request you. Yeah.
Yeah, okay.
Thank you, sir. Thank you.
Coming to history of peritonitis, patient has a swelling on the left side of the neck, which is behind the angle of the jaw and below the ear lobule for the past 8 months. It is insidious onset, gradually progressive in size. The swelling is not associated with any pain or increase in size while having food. There's no history of any facial asymmetry, no history of difficulty in mouth opening, no history of any other swellings in the neck on same side as well as upper side. No history of any weight loss, evening either temperature or cough. No history of dysphagia, voice change, epistaxis, nasal obstruction. No history of any cutaneous lesions on the face as well as in the scalp. Coming to past history, no associated comorbidities, no habits, no history of any significant medical and surgical past history. Personal history, she takes mixed diet, no habits, bowel and bladder movements normal, no history of any weight loss. Family history is not significant. To summarize, we had a 32-year female who presented with a swelling in the left side of the neck, behind the angle of the jaw and below the ear lobule for the past 8 months.
Go ahead with the examination, please.
Examination. Come to general examination. Patient is conscious, oriented, comfortably sitting. Then ECOG was 0, moderate build, moderate knowledge, no pallor, itches, sinuses, clubbing, fetal edema, general sensitivity. Vitals were pulse rate 72 per minute. BP was 112/70 in lined up position. And respiratory was 18 per minute, and oxygen saturation was 100% at 2. On inspection, there was single 4 into 3 centimeter oval swelling, just below the ear lobule and behind the angle of the mandible. The skin of swelling appears normal, it is smooth. There are no scars, no sinuses, no visible pulsations, no enlarged veins. Shall I go forward? Should I go forward?
Yeah, go for it, please.
On palpation, my inspected findings were confirmed with respect to the shape, size, and size. There was no local rise of temperature, no tenderness. The swelling was forming consistency with well demarcated borders. It was mobile both horizontally and vertically. The skin of swelling was pinchable. No palpable neck nodes were present. On examination of the contralateral neck as well as parotid area, it was normal. Examination oral cavity and oropharynx was normal. Examination of on a facial examination, patient was able to raise the eyebrows and also able to tightly close the eyes. Was able to blow the cheek and patient was able to smile. So the facial examination was normal. First examination with a 0-degree endoscope with the nasal cavity and nasal pharynx was normal, as well as a 90-degree laryngeal examination was also normal.
So, what were your summary of your findings?
My summary is that it's only findings, ma'am. I had a
Yes,
oval,
please, only for.
yeah, oval swelling located on the right side of the in the parotid area, left side of the parotid area, and it is located in the tail region of the parotid area, and the skin was smooth or swelling with no previous scars or sinuses, and facial examination was normal.
Anything else you would want to add to your examination findings?
Yes. Examination, the neck on the ipsilateral side was also normal. No other significant cervical lymphadenopathy was noted. Apart from that, the ear examination also normal.
Any other findings which you would think would be relevant in a case where you're suspecting a salivary gland tumor? How would you rule out a deep lobe clinically?
Clinically, when I examine the oropharynx, if there is a deep lobe involvement, then there might be a bulge in the tonsillar fossa, pushing the tonsil more medially. So in that way, I can identify probably it is involved in the oropharyngeal space, deep lobe involvement.
Okay. So what's your diagnosis? Unless the other examiners have any questions on the history and examination.
Based upon the history of 8 months, it's a gradually insidious onset, gradually growing neoplasm located in the area of the parotid tail. I would think it's a benign parotid neoplasm, and most probably the most common being pleomorphic adenoma. I would think that probably my FNAC will come probably as a pleomorphic adenoma. That will be my first diagnosis.
Do Vikram or Satakshi want to, Deepak want to have any comments here?
So, Dr. Chandramohan, we would like to know the next steps that you would do for this patient. How would you like to establish your diagnosis or workup?
My first workup will be, well, I'll go for a routine blood investigation, both biochemical and biochemical, and after that, an X-ray of chest. Followed by that, I would like to have the patient to undergo a fine needle aspiration cytology to identify what is the histopathological pattern.
Sorry, I just want to ask you a question. Why did you say benign neoplasm?
Sir, there is a swelling is going gradually onset, and it is having 8 months history. Patient has no other symptoms except for the swelling. And it is located in the area not correlating with the level 2 node, nor in the 1B area, something in between in the parotid tail. So I'm thinking it's probably a parotid neoplasm. And because it is going very slowly and without any symptoms, I'm thinking it
But
is.
mucoepidermoid can go slowly. Actinic cell carcinoma can go slowly. All you know, it's a parotid neoplasm. That's all.
It's a parotid neoplasm.
By the area, location, and that's it. You can only say it's a parotid neoplasm. Haven't you ever seen a mucoepidermoid which has been growing for 8 months?
No, sir.
Have you ever seen a MEC grow for 8 months or a actinic cell carcinoma grow for 8 months? So don't commit to that in a parotid. In a parotid or thyroid, don't commit to that. It's a parotid lesion or parotid neoplasm, and you will use your investigations to find out what it is. So don't commit like that. On the other hand, obviously, if you have signs like nerve involvement, skin involvement, lymphadenopathy, or whatever else, then you can say it's malignant. But please don't. If someone told me that this is benign just by touching it and feeling it in a parotid lesion, an MEC will behave like this. Epithelial, myoepithelial carcinoma will behave like this. So you don't know. So this is my opinion. So don't try to, commit to that.
Okay.
Dr. Chandramohan, we missed that bit where you mentioned about your initial workup and imaging before FNAC. What would you like to do for this patient?
With regard to imaging, I would like to undertake contrast MRI.
Since you mentioned that you felt it is a benign neoplasm, which of course Deepak sir mentioned that you can still correct. What are your thoughts on how you proceed for imaging? When will you do MRI? When will you do anything else? Anything lesser than that? Anything more than that?
Because of the soft, it's a soft tissue tumor. I would type for MRI only, man. Anything less than that won't be good to undertake for this patient.
Any comments from anybody else?
Chandramohan, were you able to palpate the complete extent of the swelling all around? Was
Yes,
it
ma'am.
nicely mobile?
Yes, ma'am. Both horizontally and vertically, the swelling was mobile.
So why not just do ultrasonography? Why do you need an MRI in this case?
Ma'am, it will give the entire soft tissue architecture of the entire tumor. And I will even know if at all a small amount of deep lobe also is involved, which is not clinically appreciable on examination. So in that way, I'll get a overall idea about how big the tumor is. Ultrasound is again radiological observer dependent. He may interpret in a way which I may not have. So for me, radiologically, I can also see the sections, and I could also have an idea about what the extent of the tumor myself.
No, the question was very relevant. You would straight away for a swelling that is having 8 months, superficial lobe only, no nerve involvement. What is the advantage of doing an MRI over an ultrasound? If there's a deep lobe extension or parapharyngeal extension, or you had nerve involvement, or you wanted to see perineural, then I would agree that you said it was benign. So for all benign parotids, what is the advantage of MRI versus ultrasound for probable benign parotid lesion?
Ultrasound obscures the deep lobe visualization, sir, because of the roundness of the mandible. Apart from that, it is.
I don't think that's absolutely true.
I agree with you, Deepak. I don't think a good sonologist will be able to get fairly good data or information on ultrasound.
Also, just
Chan-
sorry, ma'am. I think you were asking a question to him.
yeah, so Chandramohan, do you know the sensitivity, specificity, or predictive value of the ultrasonography versus an MRI for detecting such lesions?
MRI has a high sensitivity and specificity, coming to around 80 to 90%, ma'am, in identification of the parotid. Specificity is also approximately the same, ma'am.
Is it for all neoplasms? It's for all benign conditions. It's for all malignant conditions. Is there a differentiation in the predictive values?
With respect to MRI, identification of benign and malignancy, though FNAC is actually standard identification, MRI will be adjoint to find out if it is really benign or malignant. That means based upon the MRI sequences, we can know whether it will be adjoint.
Don't dig your own grave. Tell me, what are the MRI findings of malignancy of parotid? Which sequence would you use? What is the sequence for the facial nerve? Tell me the features. Let's say 3 common malignancies: mucoepidermoid, adenoid cystic, and salivary ductal carcinoma. So all of them have a common theme on MRI. So how does it look on MRI?
The surface would be not smooth, irregular margins, and there may be a surrounding invasion of the adjacent soft tissue structures, and there may be a hyper intensity in the T1 rated compared to T2.
Sorry, I didn't understand. What did you say for T1?
T1 may be hyper intense. in malignancy.
T1 by itself will be hyperintense.
Yes,
You're saying this for malignancy.
yes, sir.
Okay, so benign won't be T1 hyperintense, is it?
Maybe, sir, but it can be, sir, but
So one clue can be added to that, that compared to benign, the malignant ones will be more cell dense and lesser mucin producing. So you can still imagine the question that sir is asking. T2 picks up exactly what, like any general T2? What
T2,
lines?
T2 what it actually takes up. So if there is more less cellularity, T2 picks up 5. More cellularity, T1 is picking up 5.
I'll partially agree to that, what he's saying. T2 won't be too bright in a malignant lesion. One question to ask here, you mentioned that you would like to establish this with an FNAC after the imaging of the choice that you are trying to establish as an MRI. So the FNAC, when you do, will you do it blind, or will you blind in the sense non-guided, or will you go back to an USG guided FNAC?
We can undertake blind FNAC here, ma'am, but USG guide is much more better because of
We are still coming back to the USG, means we cannot entirely avoid it.
the tumor is palpable and little, it's quite big, so a blind FNAC can be taken up in this case. But the better here will be always a USG guided FNAC.
So I would rather rephrase your answer like this. My initial investigation would be an ultrasound because it will help me to guide the FNAC also. If the ultrasound is non-descriptive or doubtful, I would like to proceed with cross-sectional imaging in the form of contrast-enhanced MRI. I would look at the T1 contrast enhancement, and I would like to look at the margins. I would look at the facial nerve, neck nodes, deep lobe extension, and invasion of the other structures. So I don't think you can avoid ultrasound in any parotid lesion. Most of the patients will come to you with an ultrasound, and definitely if you have solid cystic components like an adenoid cystic or in a mucoepidermoid, which has also got cystic components, your cellular yield will be better with an ultrasound guided FNA. So say that you would start with an ultrasound that will help you guide with the FNA. And then if you're not able to get relevant information from the ultrasound, you would like to move to a contrast enhanced MRI if there are other factors. Yeah.
Yes. So just to add on to what sir said, you may like to look up the ESMO guidelines if you want some more clarity on this. Your choice of investigation will entirely depend on your clinical history. If it's more towards anything malignant, telltale signs, you still can go ahead with an MRI, but again, you will be back on an ultrasound guidance in all probabilities for FNAC. But if it's benign, the first choice of investigation is preferably an ultrasound. Any further investigation for distant metastasis workup? What are your clinchers in case you want to do?
In case of this FNAC showing a high grade or something like that, then I will go on to rule out the distant metastasis in the form of either a PET-CT scan, so that it will cover the chest as well as the abdomen.
So you're saying high-grade malignancies? I didn't understand. Are you specifying any malignancy that you would like to do? Like, for example, SDC or?
No, sir. I'm just telling that in case the FNAC comes out to be a high grade, then I will go ahead to do a PET-CT. Otherwise, for this case.
But FNA is reported by Milan. So in your Milan staging, how do you fit your?
Sir, you're talking about Milan, sir?
No. How does a standard FNAC be reported nowadays?
Okay, so we follow the Milan staging, sir, of its 6-track system, which is useful for grading the cytomorphological features of a salivary gland, which helps in identifying the risk of malignancies. And also gives a diagnostic understanding of what to do next with any particular category.
Is there any word called high-grade malignancy in the Milan?
No, sir.
You just said that if you have FNAC of high-grade malignancy, you would like to do systemic evaluation for metastasis.
In Milan, there is no concern. Like only we get suspicious malignancy or malignancy.
Yeah. So what are the
But sometimes your pathologist will report high grade, right?
Yes, sir.
Yeah. So complete that answer. It's not only Milan, but the grade of the tumor. Sometimes the the pathology of the tumor is also reported. And obviously, if you have adenoid cystic or STC, you want to do a systemic evaluation. Yeah.
Other than SDC and adenoid cystic, which are the tumors or the histological types where you may consider distant workup?
Salivary gland carcinoma, repropedomatic carcinoma, and carcinosarcoma.
Okay. So and adenocarcinoma is not otherwise specified.
Yeah, that
So, also
high
considered.
grade. Yes,
Yeah,
high
they all
grade
consider
adenoma.
high grade.
Yeah.
Okay. Okay. Any other information you'll ask your pathologist to tell you?
If I apart from this, Milan staging is on there. If they want
When
to
would
do,
you consider a biopsy, an open biopsy or a core biopsy in these
Right.
cases?
so if as per the Milan, if it comes out to be a non-diagnostic or A-type of unidentified significance, where we are not able to identify what is the histopathology, we ask for a FNAC, again, video FNAC. If that also comes to be negative, then we can ask for a core needle biopsy, USD core needle biopsy. Gives a more adequate specimen and also gives us the architecture of the sample. So it can help in diagnosis, easier diagnosis. They can subject
Are
it
there any
for
pathological features other than the Milan staging on the FNAC aspirate, which may consider that you might need a biopsy for diagnosis?
A-type increased mitotic rate.
My
Any lymphoepithelial. Hello.
Yes,
Yes, so any lymphoepithelial features, you may want to rule out any hematological malignancy sometimes, which may present as that. So, in such cases, also you might want to do a biopsy rather than just an FNAC.
okay.
I think Deepak was making some point.
The same thing, Deepak. If you have a lot of lymphoid architecture, if you think it's a lymphoma, or if the patient has another primary elsewhere, and if you think it's a metastatic lesion, these are the only two indications for doing a true cut or core or whatever, or an open biopsy. So if it's lymphoma, or you think it's metastatic from somewhere else, maybe the patient had a previous SCC, or the patient has genitourinary malignancies which metastasize to the parotid, or the patient has a melanoma that's metastasized to the parotid. Those are the cases where you look for true cut or open biopsies. Otherwise, like Deepa said, very important not to only look at Milan in the reporting system, but to look at the grade and look for the cytology also.
One more to add on. Am I audible?
Yes, sir. Audible, sir.
Yes. One more to add on to what Deepak was saying. If you are planning for, if the patient is having a very advanced disease, you are planning for palliative care, so you want something to do for that patient, you can ask for also throughput biopsy, so that you can do for genomic testing also. Genomic testing also you can do that. That time also you will ask for a two-cut biopsy. Tell me most common, if you are planning to say, if you are saying it is a pleomorphic adenoma, what are the most common malignancies which will be missed out or which will be you will doubtful when you are when you are preparing it to pleomorphic adenoma, which will be saying it will be a pleomorphic adenoma or any other malignancy which on Milan. You got my point?
No, sir.
Most common malignancies which will, which you will or which anyone will be misdiagnosing it on a FNSC compared to pleomorphic adenoma.
Oh, so which will mimic a pleomorphic adenoma.
Which will make a pleomorphic.
Mucoepidermoid.
Any other? If you follow the Milan's classification, some you know, na? Library land of unknown malignant potential.
Yes, sir.
You know, na? If you have more of basilar features like pleomorphic adenoma or basal cell adenoma features, the most common carcinomas will be adenocarcinomas or adenocystic carcinomas. And sometimes epithelial, myoepithelial carcinomas also. Mucoepidermoids are mostly confused with the oncocytic cell types. If you have a FNSC, more of oncocytic cells are seen, then you will think of mucoepidermoid carcinoma. Go ahead.
To summarize, have a 32-year female present with the swelling in the left carotid region for the 8 months. Incidence onset gradually progress size, and on examination the 4 centimeters, non-tender, mobile, no signs of inflammation, no regional cervical lipidectomy, and no oropharyngeal bulge.
Yeah, I think you said this, and you also said that you'd like to do an MRI.
Yes.
And you'd like to do an FNA. And let's say that this has come as something in between. You're not sure whether it's malignancy or whether it's benign. So what will be your next approach? Obviously, surgery is the answer. So what would you like to do?
If it is coming as doubtful, sir?
Yeah, you don't know. It's coming as doubtful. The pathologist is not able to give you a diagnosis.
Then, sir, you can do one thing. You can go ahead with, even after core biopsy needle also it is negative, then we can go for conservative surgery and you can take an intra-frozen, sir.
Yeah, tell me what you'll do. You would like to do a superficial parotidectomy?
Yes, sir. Superficial parotidectomy.
Or adequate parotidectomy? What is your incision that you'd like to use? Would you use nerve monitoring? Go through the sequence of how you surgically manage this patient.
Sir, I will undertake, I will prefer for a superficial parotidectomy for this case, and I will plan my incision with the modified Blaise incision. Then after elevating the patient.
So I hope you know that there's a singly modified Blaise, there's a doubly modified Blaise that we use, there's a triply modified Blaise. Do you know the difference between the three? Man, Blaise is not the only approach. Depending on the location of the tumor, you can either do a facelift approach, rhytidectomy approach, there are so many approaches. Okay, so you'd like to do a Blaise approach, and then you would raise the skin flap, and then you'd like to send frozen. Is your frozen going to change your management?
Yes, sir. In case the frozen is coming as high grade tumor, which is high grade, then I will go on to, instead of that superficial parotidectomy, I'll plan for a total conservative parotidectomy.
Even if the disease is not in the deep lobe?
Yes, sir. In the high grade, I'll always plan for a total conservative parotidectomy.
Really? Deepa, is that the correct thing to say?
Very difficult to say because generally you will not get such high grade tumors without any adverse features on radiology. It's really going to be a histological surprise to get. something like that without having bad features on radiology or on your clinical findings. But yes, if it's a salivary duct carcinoma, high-grade adenocarcinoma, my approach would also be to do a total conservative parodontectomy.
Okay, because my extended parodontectomy is totally guided by the radiology and by the intraoperative findings. We never send frozens from here. We just do the anatomical thing. Okay, so
Yeah, I agree. I don't send frozens either for primary diagnosis, but this is a purely hypothetical situation, I guess.
yeah, I guess we don't see that many cases. So, what are the reasons for facial nerve sacrifice?
The facial sacrifice can be preoperatively, patient is already having facial paralysis, and intraoperatively are
So
seen
the
that
patient has facial nerve paresis, you will sacrifice the nerve.
paralysis.
Or paralysis.
Yes, sir.
Paralysis.
Yes, sir. Paralysis.
So even if the tumor is not involving the nerve, you would sacrifice the nerve.
It itself means that there is some amount of perineural invasion of the nerve. So
Perineural
we-
invasion is an indication for facial nerve sacrifice.
no, sir. Facial nerve, if it is paralyzed already preoperatively, it means it has been affected by the tumor.
Chandramohan, is there anything about the duration of facial palsy? If the patient has a facial palsy for 2 days, you'll sacrifice a nerve, or if the patient has it for 6 months, does it make a difference?
This patient, ma'am.
Assuming we're talking of hypothetical, suppose the
Okay.
patient had a recent onset facial palsy, would you sacrifice a nerve, or would you try some conservative measures in those cases?
We can try conservative procedures, ma'am. There's no need to sacrifice all the time. But intraoperatively, I will confirm if the tumor is away from the nerve, then I'll try to spare the nerve.
Okay. And what if the patient function and the tumor is on the nerve?
Tumor is on the nerve and we are not able to dissect the nerve out, then it is better to sacrifice the nerves.
If the patient has a normal facial function, you will not make an attempt to save the nerve?
We should always make an attempt intraoperatively to save the nerve, man. But in case we are not able to do so, then it's better that we shave a part of it, so that we can part of the nerve can be shaved off, man.
Save off or sacrifice?
Shade off. There's no concept of shaving off the nerve. It's all or none. Either you preserve the nerve or you remove the nerve. What is the shaving off the nerve? If you shave off the nerve, do you think that the nerve is going to work? What is your agenda by shaving it off? You're not getting R0 resection, nor are you retaining the function. So I don't know. What is the shaving? Either you preserve or you take off. Yeah, only two things.
So I think the recommendation is that if in the presence of a normal functioning nerve, you would aim to get off all macroscopic disease, leaving behind only microscopic disease if possible. If at any point you're going to leave behind macroscopic disease, then it will be better to sacrifice the nerve and reconstruct the nerve.
Okay.
So I think you are trying to say the same thing, but you need to put it in a more precise way so that people understand what you're trying to say. Okay. When would you call a patient inoperable?
If it is a very advanced disease, where it is involving the carotid, and if it is involving the temporal, if extending of the tumor is to the temporal bone, and if it is having a distant metastasis, then you will consider it as inoperable. Very huge disease.
What is the various terms of parodontectomy? adequate carotidectomy, superficial carotidectomy, a total conservative or total radical carotidectomy, extended radical carotidectomy.
Yes, ma'am. There are classification.
Yes. Yes.
Ma'am, adequate carotidectomy is where we take the we don't identify the parotid trunk, but we take a cuff of the parotid tissue around it. That is adequate one. Coming to supervision, we identify the facial nerve trunk, and we identify all the branches of the facial nerve, and only superficial part of parotid above the plane of the nerve is removed. Total conservative is where we remove the supervision, then followed by the nerve sparing, and then we remove the deep part of the lobe. Then we have the radical carotidectomy, where when we adjunct to that, we even remove the carotid and skin and very good. In case of radical. And there is
Sorry, what was radical again?
Radical is where we have adjunct. Apart from the total carotidectomy, we remove the facial nerve. We also tie off the carotid, external carotid artery, and also part of skin is also removed in case it's infiltrated now.
Okay.
That is
And what's extended radical carotidectomy?
extended radical, where we are going to involve the, if you're planning for a there is temporal bone involvement is there, we need to do temporal bone dissection. So it will be an extended radical form.
So you just called it temporal bone dissection as a contraindication for surgery.
No, ma'am. We can do temporal bone dissection, but I found it is inoperable. Like there is gross intracranial extension of the disease. Then I'd consider it to be inoperable.
Okay, so be careful of what you're defining as inoperable. All temporal bone extensions are not inoperable. Vikram, Satakshi.
What is that
Apologies,
difference?
I was sorry.
Carry on,
Please,
carry.
please go ahead, sir. I'll ask later.
So, Chandraman, what is the difference between extracapsular dissection and adequate carotidectomy?
So in extracapsular dissection, we don't identify the nerve. We just cut over the capsule and remove the carotid. So in this facial nerve is not identified. So
Inadequate?
Inadequate, we identify the facial nerve trunk, but we take other branches are not identified. We take a cuff of normal parotid tissue around the tumor.
I think there is little bit of confusion in here. Limited superficial parotidectomy and extracapsular excision is what almost similar differences sir is asking. Do you still identify inadequate the main trunk and then don't trace the branches? I think you said that, right?
Yes, ma'am. Adequate.
For extracapsular dissection, do you identify the branches of facial?
No, we don't identify the branches.
For limited superficial parotidectomy, do we do that?
In limited superficial, facial nerve is not identified, but suppose we identify only the branches if they are exposed towards the tumor. Then only we do. That is approximately less than 2 branches we'll be able to see, because it is very small disease we are removing. So in less than 2 branches, we can tell this is partial superficial parotidectomy.
The branches which are related to your tumor in that segment.
Yes, ma'am.
The main trunk is not. I think that's what sir is asking.
Okay.
We don't.
I apologize. I missed part of your discussion. I had accidentally logged out. So for this patient, what was your suggested line of surgery?
Superficial parotidectomy. No? We didn't.
Okay. For any reason, would you like to or not like to do any of these 2 options, what Vikramjit sir asked you? Limited superficial or extracapsular? These are simpler, easier.
Extracapsular, no, because high chance of living. It's not actually All right. But I can go for adequate peritoneectomy. If it is not superficial, then adequate is the next option.
So for your patient, you said the tumor is on tail.
Yes,
Uh,
ma'am.
did we discuss about the FNAC what we got?
Yes, ma'am. We got a FNAC of this patient.
Okay, so would you still like to go ahead with a limited superficial parotidiectomy, or will you still like to go ahead with a superficial or anything lesser? I'm not sure whether madam or anybody has already discussed this.
No, it has not been discussed enough.
So your tumor is there in the parotid tail, 4
Yes.
centimeter into 3
Yes,
centimeter.
ma'am.
This is a cellular pleomorphic adenoma. Would you like to do anything lesser than a superficial? If so, why? If not, why?
No, ma'am. I will plan for the superficial only
Okay.
for this case.
Yeah, let us see the reason to it. Would you like to establish?
Now, pleomorphic adenoma is there's high chance of recurrence if you leave behind something behind. So I will always go for a superficial parotidiectomy because as per my imaging, which I'm going to show you, there is a superficial lobe involvement incomplete. So anything less than that won't be a proper surgery to be done for this patient.
That is one reason. Any other reason? One is the recurrence of the pleomorphic that you said, right? Any other reason? What Deepak sir was mentioning to you in the Milan system, how we get the salivary reportings. If we see the malignant classification also, it's not exactly corroborating like thyroid. We have the tendency to compare it with the thyroid classifications. So histopathological surprises are more. Even a proven malignancy is not corroborating more than 90% in final pathology. So histopathological surprises chances are more. Your tumor is around 4 centimeters size. So to do anything lesser than that may be suboptimal if we have a final pathology as anything different. Complications of surgery.
Ma'am, I didn't get you the voice. Actually, didn't get you the we have muted for some time.
Okay, I was asking if the other examiners, madam or sir, will like to ask you anything further about the surgical extent or complications.
There's a very interesting article in British Journal of Oral Maxillofacial Surgery in the 2000s. I think it was 2002, 2003. It was a review article. It collated data from several surgeons and several series where they looked at how do you define enucleation, how do you define extracapsular extension, limited paroidectomy, adequate paroidectomy, superficial paroidectomy. Just go. I'll try to find that article. I have it in my collection. So that has a scientific rationale behind all that. It's an old article, but I'll just try to find that article and I'll email it to Azim so that he can forward it to all of them. Okay, like Madam had said, what are your complications? So let's assume you're dealing with a pleomorphic. You're doing a superficial paroidectomy because of the size. You don't want to leave behind tissue. What are your complications of parotid surgery?
The earliest complication can be hematoma.
Sorry?
Earliest complication, immediately post-op.
Yeah.
Hematoma. Then it can also be little later complications can come to infection. Then the flap edge necrosis.
Flap edge necrosis is only if you have an acute bend and if you take it over the bony prominence of the mastoid and in smokers. Never seen it if you do it properly. Yeah, okay.
Little late, we can expect some complications like sinusite and salivary fistula. And
So why don't I'm sure you've seen many pleomorphic adenomas, right? Why patients don't develop a silocele in these cases? I'm sure you've seen many in Kidwai. And all of us have seen it. We have done cases of superficial paroidectomy. Why don't you get a salivary collection?
Sir, we have seen sinusite, sir, but
If you've seen a silocele, it's a wrong technique. Why don't you see it usually? How many case series of superficial paroidectomies have siloceles there? It has something to do with the course of the secretomotor fibers into the salivary gland.
Yes.
What are the secretomotor fibers of the parotid?
Which would supply the parotid. Those are arrays of the OT ganglion, sir.
No, tell me the end. Tell me the nerve in the end.
Parasympathetic secretomotor fibers.
Sorry?
Parasympathetic secretomotor fibers will be supplied.
Correct. What nerve supplies it and what is the course?
Auricular temporal nerve, sir.
So what is the course of the auricular temporal nerve? So it goes from superficial to deep, okay? So whenever you do a superficial paroidectomy, you actually section all the nerves of the auricular temporal secretomotor fibers. That's why you don't see in most cases. Some patients who you don't advise them to stay off bitter foods or silogogues in the post-op, they might have some redness and inflammation, but generally it doesn't happen because the secretomotor fibers go from the superficial to the deep lobe. So when you remove the superficial lobe, you remove the secretomotor fibers to the deep lobe. There can be some autonomous secretion, but it's never a problem. Okay, so you said that. Fine, what else?
Very late, we can have even Frey syndrome, sir.
Okay, how do you diagnose Frey syndrome?
Patient will come with complaints of whenever he's chewing.
I asked you, how do you diagnose Frey syndrome? Patient comes to you with abnormal sweating, but how do you diagnose Frey syndrome?
Sir, we do the starch iodine test.
Tell me the starch iodine test. How do you do it?
We actually paint the skin with iodine and allow it to dry. After drying, we powder the starch over the area. Then we give him something sauce like a citric cytochrome. So when he chews, then there'll be small areas of the.
So what do you paint basically? Which areas do you paint?
The skin overlying the parotid where we have.
That will obviously show, but is that Frey syndrome? What is Frey syndrome basically?
Sir, there is a cross innervation of the parasympathetic postganglionic fibers into the sweat glands.
So have you seen a Frey syndrome? Where do they sweat from?
On the skin, where overlying the parotid.
Overlying
parotid area. Cheek.
So that is where they
Preauricular
sweat from, is it?
Preauricular, yes, the cheek and.
So is there a standardized way of testing Frey syndrome? Who's the guy who gave the standardized testing of Frey's? Anyway, this is all benign stuff. So let's not discuss that. Okay. So you have done the superficial parotidectomy and what is the, it comes back as malignant. Okay. You have done the superficial parotidectomy and the final histopathology report comes back as malignant. What are the indications for post-op radiation in a malignant salivary gland neoplasm? Parotid neoplasm.
So the final HPR is mentioning the margins which are positive margins, present of T3, T4 high-grade tumor, and in case of perineural invasion, lymphovascular invasion.
Lymphovascular invasion. Where is it given like that?
So,
So I agree, high stage, high grade, margin positivity, lymph node positivity, and adenoid cystic. So in my book, these are the indications for post-op RT. But I don't know if lymphovascular invasion is mentioned specifically anywhere that it's an indication for post-op RT.
what we mentioned in the ASCO guidelines.
Okay, I didn't know that. So in salivary gland, you see for lymphovascular, if that's the only factor, you would give post-op RT.
Uh,
Just to add to the complexity, adenoid cystic, if you have a small, for example, a T1, would you still go ahead and give RT? If yes, do you know any evidence to it?
Only T1, no, ma'am. There is no.
You sure on that?
For T1, you won't give, is it? For
Adenoid
adenoid
Low grade and T1 is not.
Okay, so tell me the grading of adenoid cystic. What are the three grading systems?
One is Fuzzy, sir. Xanto.
Mhm.
There is a spiral classification. Spiral.
So what do we follow now?
Fuzzy, sir.
So you know that there is a staging system for MEC also, right?
Yes, sir.
I think Sarvani ma'am has added, I presume Sarvani ma'am in the group has added as well that all adenoid cystic
Yes.
carcinomas you have to give, and there is a large NCDB database suggesting exactly looking into that. T1, T2 adenoid cystic also benefits from radiation adjuvant therapy.
Yes. Okay, you have done the parotidectomy and whether you, this is a sort of, do you preserve the greater auricular nerve in all cases, or what happens if you section it, and what is the long-term outcomes of those patients?
Sir, we can sacrifice the anterior division of the greater auricular nerve, sir.
Yes.
We can like the posterior because it's applied the lobe, helping sensitivity of the lobe.
So according to you, if you section, if you, so what are the, do you know any data that has suggested that even if you section the posterior branch of the greater auricular, I never preserve any greater auricular in my parotids because all my patients, when you stretch the greater auricular, come back with severe pain and dynia and all that. And I wasn't taught to preserve it by Jonathan, so I section all of my greater auriculars. Do you know if any data of return of function of the ear lobule? There's lots of data, so many papers. Yeah, so there are at least 2 systematic reviews, if I remember, which have said that the facial nerve re-innervates the lobule and patients don't find as much of a problem. I agree that you have to preserve, but I wasn't taught that way. So I usually remove it, cut it and clip it so that it doesn't form a neuroma, but it does recover. So you don't have a problem with that. So how do you prevent Frey syndrome?
So, for that, you should raise a thick flap. Thin flaps should be avoided. So that is the way to prevent Fray's, sir. And if at all thin flap is elevated, you can put an interposition soft tissue so that the skin and the leftover facial nerve between there will be an intermittent soft tissue. Like put fat or temporal peripheral fascia or sometimes we can take a part of the SCM and put it in.
What part of SCM?
Not parts of mix, not actually SCM, basically more amount of fat and temporal
Yeah, you have to put an interpositioning graft if you can't harvest, you can't raise a thick skin flap. That can be derma fat, it can be dermal substitutes. I'm talking benign cases, I'm not talking malignant cases. Or you can put vascularized tissue. In this group, I would never advise anyone for contour correction to take the SCM and plug it there just to give fullness in the parotid region. Either do a smash flap or do a derma fat graft or do some vascular thing, but don't ever, you should not sacrifice a donor site because sacrificing the SCM is a big thing. So don't do it. So yeah, make a thick flap, put an interpositioning graft there so that doesn't. Okay, so this patient came to you post-op with facial paresis. What would your advice be?
Paresis.
Paresis, yes.
So if it is paresis, then we can wait and watch, sir, because patient may have some recovery. I would suggest for rehabilitation, and if at all based upon the nerve which is affected, like if it is eye branch, then because it is paresis, I'll go ahead with protection of eye, like taping in the night and lacrimal drops for protection of the cornea, sir. And probably to recover because in the little time.
Do you know of any drugs that have shown to hasten facial nerve recovery?
Steroids we can use, sir, but they're not sure about it.
Nimodipine, calcium channel blocker, nimodipine. Yeah. Nimodipine has shown to hasten the recovery of the facial nerve. And all the other things that I mentioned in the presentation. Yeah. I think, Azim, are we out of time?
I think, yeah, this is, if there are any specific, like we can wind off in the next 5 minutes.
And I think Deepa ma'am has shared the ASCO guidelines. So anybody, if they want to download it or check it.
And I'd also request that we had put in a poll for the feedback. So anybody who would be interested in like presenting and what topics you want in future, and any specific comments and feedbacks, you can please put it there. And definitely we'll get back to you. And we also have a YouTube channel, and all these lectures are available on the YouTube on Mahamana Head and Neck Oncology. So you can also subscribe to that channel for future references for these sessions.
So Dr.
Deepak sir, any specific comments? Satakshi, Deepak sir?
No, I would just like to thank Dr. Chandramohan for presenting. It was a nice presentation. I personally got to learn a lot from the seniors and his own presentation. A lot more scopes to discuss, but I think for the lack of time, we can end it there.
Yeah, one last question to Chandramohan. This is like your gold medal question. In an adenoid cystic carcinoma, how far will you chase your nerve?
So the maximum I will chase to is the second genus. Beyond that, I don't want to chase.
Sorry, how far will you chase it?
Second genus means along the, I'll go the dissect the nerve through the stylomastid foramen, go up to the mastoid segment, drill it, and beyond that, if I still find my comfortable positive, I don't want to go beyond that. So.
Okay, but this is how do you decide? You know that adenoid cystic, you can have even skip metastasis have been
Yes, sir.
disproved and all that.
Yes,
But
sir, skip.
Azim just posed, we'll discuss that in the temporal bone malignancy session. That's a big discussion and big questions. Azim, we'll wind up.
Yes, sir. So thank you everyone for joining. Thanks a lot, Chandramohan. Thank you, Deepak sir. Thank you, Satakshi. Thank you, Deepa ma'am. And Vikramjit sir. Thanks everyone. And the Prakash Munda, yes, commented upon the CA larynx is a lot of controversy. We'll definitely have larynx sessions separately. We had 2 larynx sessions just prior to this, and we'll also be having in future. So everybody please put in the poll questions, and we'll definitely get back to you for those specific sessions. Thanks a lot.
Thanks, Azim. Thanks, everyone. Chandramohan, well done. Yeah. Okay.
Thank you, sir.
Yeah. Yeah. Bye.